Good afternoon. We are starting our clinic very shortly. We are waiting for Central Team Division to join us, and they are going to join us, I think, within the next 30 seconds. Welcome to today's NITRD Central TB Division and National Task Force Collaborative Difficult to Treat TB Clinic. I am Dr. Neeta Singla, and on my right is Dr. Rupak Singla, who's head of the Department TB and Chest. And on my left is Dr. Saroj Meena. She's a pulmonologist at NITRD. On behalf of NITRD, welcome DDG sir and his team. We have Dr. Ravinder joining us very shortly, and other members of National Task Force and Zonal Task Force. We have directors of NTI Bangalore and NIRT Chennai, state TB officers, district officers, faculty from medical colleges, and others. Today's case is from the state of Odisha, and we are joined by the state team. Dr. Prashant Kumar Hota, who is the state TB officer. Sir has joined us. Sir, a very warm welcome to your team. Now I request our director, sir, Dr. Ravindra Devan, to give his introductory remarks. Over to you, sir.
Okay. Yeah. Good afternoon, everybody. On behalf of the National Institute of TB and Respiratory Diseases, I express my sincere gratitude and thanks for having joined. Already 160 plus persons have joined. I'm sure this will be a meeting as vibrant and as interesting as it had been on previous occasions. And best wishes for the meeting. Thank you, Dr. Neeta, and my team includes here from NITRD, Dr. Neeta, Dr. Rupak, and Dr. Saroj, who you can see on the screen. They're the persons engaged with this, continuing this program. Thank you so much and best wishes. Thank you. Carry on.
Thank you so much, sir. Dr. Ravinder from CTD would be joining us shortly, so I will invite him as soon as he joins us. So today's case presentation is from Odisha, and Dr. Arvindo Behra, who is the assistant professor in Department of Pulmonary Medicine at Vimsar, Odisha, will be presenting the case. The state expert is Dr. Sudarshan Kothal, a professor, Department of Respiratory Medicine at Sri Jagannath Medical College at Puri. And national expert for the case would be Padma awardee Dr. Behra sir, who is currently Emeritus Professor in Department of Pulmonary Medicine at PGI Chandigarh. Very warm welcome to the entire team. And now over to Dr. Arvindo Behra for his case presentation.
Thank you very much, ma'am. Is my audio clear?
Yes, I can hear you.
Yes, sir. Yes, sir.
Yes.
Join here.
Respected dignitaries, Dr. Joshi, DDG TB, Padma Shri Professor D. Behra, the national expert for today's session, Professor Diwan, Director of NITRD, Professor Bharadwaj, and respected dignitaries from NITRD. So, good afternoon to all the respected delegates also. Can I share my screen, ma'am?
Please share the screen.
So, on behalf of the Department of Pulmonary Medicine at Vimsar, Kurla, Sambalpur, from Odisha, I welcome everyone to this session. So we are going to discuss a nice case, and we faced a lot of difficulty in this case. So I'll straight away proceed to the case. So we had a patient, Sri SP.
Sorry to interrupt you. Can you make it on presentation mode, please?
Yes, it's already.
Maybe you need to reshare. Maybe stop share and reshare it again.
Okay. Yes. Yes.
Welcome, Dr. Rajendra Prasad, sir.
A little join, little late. Yeah. Driver साहब,
Welcome, Dr. Jaikishan sir. Is it on presentation mode from your side?
No, ma'am.
Dr. Ravinder from CTD, sir, are you there?
Yes, I am there, ma'am.
Welcome, Dr. Ravinder. So, till the time Dr. Arbindo sorts out the presentation issue, sir, invite you to say a few words. Dr. Ravinder.
प्रेजेंटेशन होने दें या फिर आप चाहते हैं हम स्टार्ट करें?
As you wish, because we thought you're short of time. So, if you have time to wait till presentation, we can invite you after presentation.
So already you have started presentation. Anyway, thank you. Welcome all, Dr. Rajendra Prasad and all degrees and all senior consultants from the country, Dr. Singla, Dr. Nitya Singla. Now all the members who have joined this very important difficult to treat clinic at national level. As you know, this initiative was started by our institute, that is NITID, to discuss the difficult to treat cases reported all over the country at the national level for the cross learning of all the consultants, all the field consultant, as well as the doctors in the field who is dealing with the tuberculosis, and how we can manage these difficult cases and how our national guidelines can be implemented. And everything is mentioned in our national guidelines, how we utilize these guidelines, what are the options for the changing of the treatment, what are the drugs which can be used as a replacement drug for these difficult cases. So it is a very good initiative, and even many states also started their own difficult to treat clinic in the consultation with our national difficult to treat clinic. So first, many congratulations to NITID to starting this very important initiative, and looking for the fruitful discussions ahead. Thank you very much.
Thank you, Dr. Ravinder. Thanks a lot. Now, I would request Dr. Arbindo to present his case.
Is it in presentation mode, ma'am?
No, it is not. But if it is not switching, it's okay. You can.
At my end, it's showing presentation mode.
Can you share the whole screen? Not on the PPT. So once you're clicking on the new share, the first window you are seeing is the screen.
Yeah.
Click on it and share it.
Okay, is it now?
Yes, sir.
Better? Is it in presentation
Yeah,
mode?
it is in
Yes,
presentation.
now.
Yeah, thank you. So we had a, sorry for the glitch. So we had a patient called Shri SP, who was a 50-year-old male. He presented to our emergency department with history of productive cough for 7 days, generalized swelling of body for 7 days, and loss of consciousness for 1 day. His cough was associated with low-grade intermittent fever and exertional dyspnea for last 6 months prior to hospitalization. And patient was diagnosed as a case of microbiologically confirmed pulmonary TB on the 19th of July 2021. A patient was admitted to us. He presented to us in January of 2023. His cough was productive of copious mucopurulent sputum. It was non-foul smelling, and it was associated with scanty hemoptysis. His swelling started from both legs, and it progressed to involve the entire body over the last 7 days prior to the current hospitalization. His loss of consciousness was acute in onset and was not associated with any history of fall, head injury, or convulsions. In past illness, he had a history of pulmonary TB 10 years back. He is a known case of type 2 diabetes mellitus for the last 10 years, but is not a known case of hypertension, obstructive airway disease, chronic kidney disease, hypothyroidism, or seizure disorder. Coming to treatment history, he had taken antitubercular therapy DOTS for 6 months about 10 years back, and prior to current hospitalization, he had taken first-line drugs for 4 months till November, and he had discontinued for 2 months prior to the hospitalization episode. For diabetes, he was on oral hypoglycemic agents like glimepiride 1 milligram and metformin 500 milligrams once daily for the last 10 years. There is no history of use of any beta blockers or diuretics. He used to take alcohol regularly, but he is a non-smoker. No other addictions. On examination, at presentation, his blood pressure was 120/80, pulse rate was 90 per minute. It was regular. The oxygen saturation by pulse oximetry was 96% on room air, and respiratory rate was 18 per minute. He was unconscious. He had generalized edema with raised jugular venous pressure. His skin was cold. We did a random blood sugar at the emergency, which came out as 60 milligrams per deciliter, and patient was administered dextrose infusion, following which he regained his consciousness. So we made a diagnosis of microbiologically confirmed pulmonary TB, that's a recurrent TB with loss to follow-up with congestive cardiac failure, with diabetes mellitus, with OHA-induced hypoglycemia, and we hospitalized him to our department. We did a non-contrast CT of the brain at the emergency, which showed age-related diffuse cortical atrophy. So this was the X-ray at presentation. We can see there's presence of cardiomegaly, and there is non-homogeneous opacity in the left upper zone, some confluent opacities in left mid zone, but lower zone is not quite visible. We did a CBNAT of the sputum, and it showed MTB detected medium with RIF resistance on the 25th of January 2022. So we diagnosed him as rifampicin resistant TB, and we went for the pre-treatment evaluation before starting the second line drugs. So on cardiological evaluation, the 2D echocardiography revealed the presence of dilated cardiomyopathy with severe left ventricular systolic dysfunction with global hypokinesia with an ejection fraction of 26%. He was having moderate PAH also, for which he was advised as tablet digoxin, furosemide, metoprolol, and dapagliflozin by the cardiologist. We did an ophthalmological evaluation before starting linezolid, and it showed relative afferent pupillary defect with optic neuritis of right eye. Also, we went for an ultrasound abdomen, which showed hepatic parenchymal disease with prominent hepatic veins, the gross ascites, bilateral mild pleural effusion, along with pericardial effusion. The pre-treatment serum T3 was 1.1, T4 was 73, and TSH was elevated at 14.1 micro international units per ml. And patient was started on levothyroxine 25 microgram OD. The serum albumin was 2.8 grams per deciliter. The QTC Fredericia was 413 milliseconds. And because of hypoalbuminemia and anasarca, patient was infused with 1 bottle of 20% human albumin, but albumin still went on declining during the course of stay. So the patient was started on, we had difficulty in managing the patient, although, so we took around 15 days to start him on second line drugs because the QTC was becoming prolonged and it was difficult to manage his anasarca, and patient was also not taking orally. So we first stabilized the patient, and once he was a bit relatively stable, so we started on bedaquiline, amikacin, levofloxacin, cycloserine, and clofazimine. Now, why we omitted delamanid, we omitted linezolid because of the optic neuritis, and delamanid due to hypoalbuminemia. But 5 days later, we had to stop bedaquiline because patient's general condition deteriorated and his liver function was deranged with hyperbilirubinemia. And the remaining 4 drugs were however continued along with medications for dilated cardiomyopathy. So on 17th of Feb, bedaquiline was again resumed following improvement in the serum bilirubin, and it was continued till 26th of February, and it had to be stopped again as the patient developed digoxin toxicity. Now he was on digoxin for the dilated cardiomyopathy, and he developed ventricular bigeminy. So along with bedaquiline, we also had to stop clofazimine, digoxin, and metoprolol as per the advice of the cardiologist. And we was started on oxyprenolin 10 milligram PDS because of bradycardia. So as ATT, we continued injection amikacin, levofloxacin, and cycloserine. Later on, we went for an ENT evaluation because the patient was complaining of little bit of hearing loss. So on ENT, the ENT evaluation showed mild sensory neural hearing loss in left ear and minimal sensory neural hearing loss in right ear. So we had to discontinue amikacin as well. So as per the replacement sequence mentioned in the national guidelines, the next drug was pyrazinamide, which was added to the regimen. So this table is showing the important investigations done. The WBC was showing the decreasing trend. Albumin is showing the decreasing trend. Bilirubin was elevated on 15th. We stopped the bedaquiline, but again resumed because of reduction in the bilirubin levels. The TSH was elevated at the time of pre-treatment evaluation. So he was on levothyroxine. The electrolytes were pretty much within the normal range. QTC was prolonged. However, it started coming to the normal value later on. So we continued these drugs. So what all drugs we excluded from the regimen? We excluded linezolid because of the presence of relative afferent pupillary defect with presence of optic neuritis in the right eye. Delamanid was not considered due to persistent hypoalbuminemia despite infusion of human albumin. Amikacin was excluded due to the development of sensory neural hearing loss, and ethinomide as such was avoided due to the presence of hypothyroid state in the pre-treatment evaluation. So we faced quite a bit of challenge during management of the patient, but fortunately he tolerated all the drugs. After infusion of albumin, somehow all the levels were not improving much, but his anasarca started coming down and he was able to take oral diet. And then his QTC was also remaining within the normal values, and he was tolerating the drugs. So we plan to discharge the patient on the 31st of March in a stable ambulatory condition with the following regimen. So we gave bedaquiline 200 milligrams thrice weekly because he had already taken 2 weeks during hospitalization itself, and levofloxacin, clofazimine, cycloserine, and pyrazinamide along with bedaquiline. And as per the advice of cardiologist, we continued with furosemide, metoprolol, and metformin. Also, pyridoxine 100 milligrams OD was given. So we tried to keep track of the patient. He did not come back for physical follow-up to us, but over the telephonic information, he was doing all right. But unfortunately, he expired on the 25th of May this year at his residence. When we inquired from the district DRTB center, their information was that he had developed vomiting one day prior to his death. But they also said that he had again developed the swelling of all of the body for last few days before his death. Unfortunately, we don't have any first line or second line LPA and culture reports, and we could not receive them from the IRL of our state. So this was my presentation, and with this we had a set of questions for discussion, and which I would like to continue with the permission of the House. So I would like to invite my state expert, Professor Puthal sir, to kindly go forward with the discussion, points for discussion. So our first issue was what should be the proper regimen for this patient.
Thank you, Dr. Arvindo. Before we take expert opinion of our expert, we would like to open the session to all the participants if they have any questions regarding the history of this patient. So people who have participants who have joined us little later and might have missed the case history, I will in very short brief that this is a DRTB patient from Orissa, and he was diagnosed as RIF resistance, and he was a known case of diabetes and he was a known alcoholic. He had congestive heart failure and he had optic neuritis. He also had hepatic parenchymal disease and he had raised TSH levels, and he also had hypoproteinemia. So he had several comorbidities. And then he was put on second line treatment, and while on second line treatment, he developed a lot of adverse drug reactions like ototoxicity and cardiotoxicity. So that is the case, and I would now open it for discussion with Dr. Arvindo regarding the case history. Can you stop the screen share?
Yes, ma'am. Yes.
Thank you.
Window,
Yes, sir.
whether you see in your history that he took 6 months of CAT1 before. So what was that treatment? Whether he was regular, irregular? It was not very clear from the history.
Sir, as per the patient's version, he had taken regular treatment and he had completed 6 months of CAT1.
Because there are two issues. We always have taught to our student when TB patient with alcohol, and it is most difficult one to kill, and they are alcohol point of view, they are most difficult to be believed. So because it has developed distance, must be something history. Why he has developed?
Dr. Arvind,
Yes, sir.
it was a dots or non-dots based?
He says dots, Dr. Vera.
He said dots, sir. First time he took CAT1, that was dots, sir.
So what was the gene export or true not? What was it during the first time, and also during the second time when he reported to us? But I think 4 months before that he had taken a TT, right? So what was spot during these 2 times?
Sir, first time there is no documentation of gene expert report. It was 10 years back, sir. And second time when he started, he was diagnosed in July of 2021. That was by microscopy. Gene expert was negative on that occasion, sir. Gene expert turned out to be positive when we hospitalized at our department.
I'm sure the report was there, gene expert is negative, and after 4 months it became positive.
Yes, sir. Yes, sir. In July it was negative, sir. At his district, it was negative.
Okay.
His sputum was positive and gene expert was negative at that time.
Yes, sir.
That's very rare combination. Okay, it may happen. Anyhow.
Okay, anybody has any other point to tell? You see, again, may I start, or anybody wants to tell anything else?
So there is a question on chat. We are taking up the
One
question.
question, creatinine levels during the treatment period. Creatinine levels during the
Yeah, creatinine levels were normal, ma'am. Creatinine levels were normal.
and there was a suggestion that why was ethanamide was like he was diagnosed with hypothyroidism. So alloxin was not increased. The dosage of alloxin was not increased.
Madam, yeah, alloxin was increased to 75. Alloxin was increased to 50 micrograms during the hospital stay.
You see, actually, in these cases,
Previously, what we used to do was in cases who have high TSH, we used to avoid giving thionamide or PAS. But now the current thinking is that we can, if required, we can give these drugs and simultaneously give altroxin and adjust the dosages so that we are not denying any good drug to the patient. So that could have been considered that if required, we can choose thionamide, but at the same time treat the hypothyroidism with the altroxin. So that is, thank you.
Thank you.
Singla, I agree with Dr. Singla. You see, the ethionamide should not have been stopped. You could have monitored. Because my first point is there are a lot of comorbidities, as Nita has told very clearly. Why did the patient should have been in the hospital or in the DRTB center little longer time? Because he has got multiple, not only one, he has got multiple comorbidities. So he should not have been sent home so quickly. This is number one. I think that you need some policy about that. Obviously, there is no bar in keeping the patient little longer. So he should have been on constant vision. This is number one, unless he did not agree or I do not know what was the reason. And number two, as regards the ethionamide, I think Dr. Singla has already told that that could have continued with the thyroid function monitoring and giving him altroxin. And what about Ethambutol, Dr. Singla, in your opinion?
Sir, in this case, patient had documented optic neuritis.
Optic
Although
neuritis.
it was not retroviral neuritis, but plus reaching up to the level of ethambutol in the replacement sequence was, I think, not required in this case. So that's why, because of these two reasons, they may not have considered ethambutol. Because we had other better drugs higher up in the replacement sequence. And I think it was a very challenging case, which they managed very well.
Let's hear Dr. Sudarshan Kothal first.
Yeah, exactly.
That will be the sequence.
Yes. Dr. Sudarshan, he's Professor, Department of Respiratory Medicine at Sri Jagannath Medical College at Puri. Sir, we would like to have your comments.
Yes, sir. Yes, madam. I want to share my screen. Is it visible?
It is visible.
Okay. Respected Padma Shri Professor Digambar Behera sir, Professor Diwan sir, Dr. Singla, and all dignitaries present in the webinar. First of all, just I want to give this PowerPoint presentation in form of particularly this case, related to this case. How we recall or how we remember this replacement sequence. As you know, it's very difficult to remember. That's why we form a mnemonic like diazepam, so that we can remember the sequence of replacement and group C drugs. Whatever the point of discussion is given by Dr. Behera, the 4 points they have highlighted. Out of 4 points, I want to discuss one by one. Number one, particularly as we just recall our the launch Denamolide in 2018. In that guideline, they have mentioned particularly two important parts, particularly that special caution about the serum albumin if less than 2.8 and alcohol. But at the same point, they have mentioned that Delamanid may be considered with caution by Nodal DRTB Center committee under specialist consultation in patient with baseline serum albumin less than 2.8, but it required frequent monitoring of the serum albumin. Recently, I come across a literature. This is the snapshot of the literature just published in 2022 in the month of June. This particularly based on this study, the author point out that even though Denamolide has been shown to be metabolized into DM6705 by albumin in vitro, but in individual plasma albumin level were not found to impact in Delamanide metabolism or kinetic. Based on this, I think probably in this case, we can start delamanid with caution, I mean to say with frequent albumin monitoring. Second part here, some issue what already has been discussed regarding the hypothyroidism and ethionamide. Yes, hypothyroidism is a reversible side effect, is a reversible adverse effect. That's why, to me, yes, it can be given, ethionamide can be given with modification of thyroid drug. Second point, particularly in this case, some cumulative adverse event may happen, or we have to alert, particularly as patient is on furosemide and amikacin, both can potentiate the ototoxicity. And simultaneously, as we know, levofloxacin can cause hypoglycemia in concomitant use of oral hypoglycemic agent. We know that particularly levofloxacin is rare or less common in age compared to say moxifloxacin as regard to hypoglycemia concern, but still is possible. Third thing is about dilated cardiomyopathy with QT prolongation drug. Yes, we know QT prolongation is a electrical activity, whereas dilated cardiomyopathy is a structural activity rather. But logically, a structural enlargement may not impact on electrical activity. Based on that, our cardiologist advised that still the bedaquiline can be given. But based on few literature, just came across a few days back, in this article, they have pointed out that the prevalence of QT prolongation in healthy population is hardly less than 1 in 200 population, whereas in DCM people or dilated cardiomyopathy or hypertrophic cardiomyopathy people, patients, the frequency is quite high, means 1 out of 8. What I mean to say, the prevalence of QT prolongation in this group of patients much more higher as compared to normal healthy population. In this context, particularly if the first question is arise at the proper regimen, to me, I think a regimen first bedaquiline, levofloxacin, clofazimine, and cycloserine. Instead of say linezolid, I will prefer, definitely linezolid was stopped, but I will prefer delamanid. Second question was drug-induced hepatitis in all oral longer regimens. Should all drugs stopped or only those having hepatotoxicity? As for our previous knowledge is concerned, that in our both in drug sensitivity and drug resistance TB, once hepatitis occurs, the hepatotoxic drugs should be stopped. Not all drugs. Like in this case, definitely they have done the good job. Like bedaquiline was stopped, because in this regimen, the bedaquiline is the most important hepatotoxic drug. But still, levofloxacin is possible, but not that much common. Third question is, can delamanid be considered the patient despite presence of hypoalbuminemia? To me, yes, it can be done. It can be given. Fourth point is, in this patient, in use of oral hypoglycemic agent, ideal to control blood sugar or insulin should be given. Basically, as we know that particularly in the rifampicin-based regimen, rifampicin is a hepatic inducer enzyme which decrease the plasma concentration of certain oral hypoglycemic agent, particularly sulfonylurea. But fortunately, in this regimen, there is no rifampicin. That's why I think OHA, if through OHA, hypoglycemia or a glycemic control is achieved, means OHA can be managed with through OHA. This is all thing about my suggestion in this point of time.
Thank you, sir. Thank you, Dr. Arvindo, and thank you, Dr. Sudarshan, for such a nice presentation and clarity on the case. Now we open this case for discussion. We will take up the questions. You may raise your hand if you have a question, and meanwhile we take some questions which are there on the chat.
Dr. One question I want to ask the presenters. Sure. That is the loss of consciousness just related to hypoglycemia? It never recurred again something in the brain, any other lesion, any other reason for the presentation as a loss of consciousness in this patient? The CNS symptoms, were they fully explained by the hypoglycemia episode only?
Sir, we did a non-contrast CT. It
You did?
did only age-related atrophy, and as soon as he was administered dextrose, he regained his consciousness. So we didn't think any other electrolyte or other disturbance.
I asked it because he died of vomiting and something. That's why some space occupying lesion in the brain was also there in this case or not. That was my concern.
Sir, if I may answer one of the questions of Digambar Behra, sir, the patient was with us for more than 2 months. And during the beginning of March itself, the patient was not willing to stay in the hospital. But somehow we kept on requesting him and persuading him to stay. And finally, when the patient did not relent at all, we had to discharge on the 31st of March.
Dr. Behra,
Yes, sir.
Arvindo Behra.
Yes.
There are two Behras now. So really, I must thank you and Dr. Pothal for clearly saying the things. One thing was not clear to me. This cardiomyopathy, when he was treated for the first time, whether it was there or it was a new development.
Sir, it was detected during the pre-treatment evaluation, sir. There is no previous documented report of cardiomyopathy. During the pre-treatment evaluation, we do a cardiological evaluation before starting the cardiotoxic, potential cardiotoxic drugs. So as a part of pre-treatment evaluation itself, it showed the presence of dilated cardiomyopathy.
Oh, that's okay. Even if you see the X-ray is very clearly showing that there was a cardiac enlargement, and you did it. So my question was whether in a previous, because in previous treatment also X-ray should have been done, I believe, must have been done. So what was the status of cardiac size and what was the status of cardiomyopathy at that stage?
There is no previous documentation.
One thing is very clear that he was a very difficult case, and I agree with Dr. Digambar Behra. Such type of patients usually say that there are hardly any indication for hospitalization nowadays. But if one is dealing with the multiple comorbidities, especially diabetes, alcohol, cardiac myopathy, then such type of cases must be, counseled to be in the hospital for a prolonged time, so that anything happen, it can be modulated. That was really because when he went home, although he was okay and he was not willing to stay, he went home, and all of a sudden something has developed because of omitting. We don't know what has happened. It was a cardiac toxicity because sudden death. It was hypoglycemia. So these are the two things which comes to my mind in such type of cases. It may be some cardiac toxicity because he was a difficult patient, alcoholic. Alcohol use was very regular, I believe. So anyhow, in the meantime, we have lost this patient. But I think whatever management has been done properly. But history taking, I will again say, if somebody has 4 years back, he had 6 months of treatment, that too was under DOTS. I don't know whether X-ray was done, whether he had any previous X-ray available.
No, sir. No, sir. He did not have any previous documents, sir. A very poor patient.
He did not have any previous. Okay.
At this stage, the rest of the comments will come later. Since we are discussing about the dilated cardiomyopathy, when I looked at the X-ray, it seems it is typical like when we were undergraduate students, we were told money bag appearance.
Yes.
So it is looking to me, it looks like there may be some evidence of pericardial effusion also. And on the left side, I could see some pleural shadow also, as if there is a pericardial effusion and pleural effusion also. So can we have a look again, Dr. Bindo, at the X-ray?
Yes, sir.
That was the appearance which looked like to me.
Yes.
No,
Yes, sir.
Dr. Singla, they did a echocardiography also, na?
Yes.
They could have detected the pericardial effusion.
Yes, sir. In echo also, sir, there is pericardial effusion and bilateral pleural effusion also.
Okay.
There is a condition alcoholic cardiomyopathy also. This patient could have had
Yes,
that also.
yes, yes.
So just show the X-ray, please, Dr. Bindu.
Yes, sir. Is it
You-
visible, sir?
Yes, sir, visible, visible. Go to the slide showing
So
X-ray.
please go to the new share.
Sir, I'm focusing the X-ray slide, sir.
So please click on new share, sir, and select the first screen.
Okay, yeah, sure.
New share now, okay.
Is it
Yes.
visible now? Yes.
So you see, it is typical, like to me it appeared the moment X-ray was shown that money bag appearance, like ladies.
Yes, yes. You are right, Dr. Singla.
And on the left side, the pleural effusion also seems to be there at least.
Fluid on left and even on right CP angle is appears to be obliterated. Right castophrenic angle is also appears to be obliterated.
Although
He was
saying,
a smoker or non-smoker?
Non-smokers.
Non-smoker.
although treatment would have been same diuretics and the this drugs for managing the cardiomyopathy, but
Right.
these are the additional things which were there. So we may not, and I think they are saying that on echo also it was confirmed. So that's okay. So at this stage, I would like to say this: as the discussion goes on, I will have my further comments. And anything else from the
Another issue, Dr. Singla and Dr. Behra, Digambar Behra. In this case, as we move from state to state, the similar situation it appears to in Odisha that LPA1 and LPA2 and culture reports has the similar problem, because in this case we don't have LPA2, because a case who has shown rifampicin resistance on a gene expert, now LPA1 and 2 are must to know that whether there is a further drug resistance or not. So I think it's same situation. Dr. Digambar Behra is also there in the Odisha also.
No, it is not a, I think few months back we had also discussed the same thing. Fluoroquinolone resistance test is not available. Then these are the larger issues, because we are discussing it is okay academically, but I am sure the program must take care of these things.
Yeah.
It is not only in Odisha, it is everywhere. I think yesterday in the ICMR meeting, Dr. Singla was there. We had similar issue. Things are not available. Center is telling the states should get it, the LPA, whatever the reagents. Then the states are telling we don't have the, I think these are the issues that need to be sorted out by the program. Right. Dr. Singla, you remember yesterday discussion?
Yes, sir. Because states have not budgeted this. States have not budgeted for this. Suddenly it came to them. So ultimately the patients are being denied the benefit of these genotypic tests, which can really be helpful in the field condition. So that is there, sir.
I think the CTD should take care of these things, because CTD and the states. I remember the last time I was also discussing a case, similar case, and then you had the same issue. We don't get then you see, how are you going to end TB by 2025 if you don't give the simple LPA reagents? We are not having facility for the fluoroquinolone resistance to know, and the other cultures, as Professor Rajendra Prasad pointed out. So I think these are the issues we should take care of, should be taken care of by the program and the states. It is their job they have to sort it out. And it is going on for over a year now. So that will be one point. It seems to be something as if I am trying to criticize somebody. I am not trying to criticize anybody. My only point is that I think all of us, there are so many people sitting, STOs, DTOs are sitting, then maybe one of them can give a comment.
Yes, definitely.
Thank you, sir. We have two hand raised from Dr. Sudarshan and Dr. Jaikishan. Dr. Sudarshan, sir, and then we'll go to Dr. Jaikishan.
Yes, sir. Actually, just few days back, I talked to our microbiologist.
Yeah.
Just few days back, I talked to our microbiologist colleague, he told that the load, the large number of load is there. That's why report could not generate in a proper time. But thing is that, sir, second lab was already constructed at Vimsar, at Burla. But unfortunately, everything is ready. But unfortunately, the personal part is the issue. That means neither LT nor any microbiologist yet to first aid is there, so that the lab is not functionalized. What I mean to say, if there's any intervention or any sort of effort from the CTD about the say recruitment of personnel to the Vimsar new lab, so that we can functionalize the lab properly, so that probably the load will be decreased, so that we can put our culture DST report in time.
Thank you. Thank you, Dr. Pothal, sir. Dr. Jaikishan, sir, your comments.
Unmute.
Sir, you need to unmute yourself.
So there are two issues. One is the care at the medical college level, and which we consider that this is up to the mark and the patient had improved a lot. But now the care in the periphery, whether the quality of the care in the periphery is up to the mark or not, whether the accessibility to the services is there or not. The patient had developed the similar complaints in the periphery, whether he approached the peripheral health services, whether the quality care was given or not, whether he at all approached the peripheral health services, what the DTO did in such like a scenario where the patient is having multi-morbidities and others, whether the multi-morbidities like diabetes care and the cardiac care medicines were made available to the patient or not. That is a big issue, and what is there is under the program, we are not providing these medicines for the comorbidities and the complications and the primary health. That can be one cause of the death. And the other issue is that the patient was being called and whether he was regularly followed or not, whether the death certificate was done by the DTO or not. So these are the issues which are to be addressed at the periphery level. We have to maintain the quality of the care at the peripheral level as well, beside the institutional medical college level care. And like you said by Dr. Behera and Dr. Rajendra Prasad sir, that whether in such a scenario where the patient is having comorbidities and patient is seriously ill with all these conditions, whether the hospitalization can be prolonged, or in the peripheral, whether patient should be have the license with the institutions which can take care of these complications at the earliest, because if the time it is lost, the patient gets lost. That is what is my comment.
Thank you, sir. So what I'm getting from this case is that at periphery, we have to be very careful for screening of comorbidities. Whatever screenings are available in the periphery, like for diabetes, HIV, thyroid, they should be done seriously. And all the patients who have multiple comorbidities or serious comorbidities should be managed at bigger hospitals. So they should be referred in time to bigger hospitals and they should be managed. This is what I'm understanding from this case. We also have team of state team from Odisha. So I would like to invite STO sir from Odisha to say a few words how the program is doing in their state, and are they having difficult to treat TB clinic in their states.
Good afternoon, ma'am. Am I audible?
Yes, sir, you are audible, sir.
Ma'am, as Dr. Professor Pothal said, I am to say that the HR of new culture DST lab at Vimsar Burla already approved VIP, and manager will be recruited at state level, and all LT, senior and junior LT are recruited at district level. Already we are discussion with NHM AD admin at NHM Odisha. It will be done. Another thing is now the the tender agency is doing TB containment lab area at Bhimsar Burla. The culture DST lab is not completed yet, but it will be completed soon. And I had talked to Dean and Principal Madam of Bhimsar Burla also regarding this. And second thing, as per IRL Cuttack, all lab consumable after approval from MD NSM and discussion with the Medical Corporation Limited, we are given the responsibility to IRL itself to procure all consumable LPA, whatever may be, and it will be done soon.
Thank you, sir. Thank you for your comments, but we were not able to see you, sir. We can see other team members, but we are not able to see you, sir.
Yes, madam. One thing I want to add to Dr. Hota about the state level difficult to treat clinic. Yes, ma'am, we are conducting regularly. There are roughly around probably 11 to or 12 like difficult to clinic state level clinic already by this time completed. Ma'am.
Thank you.
Can I speak?
Sure, sir.
My question remains unanswered. Whether at the periphery the quality of the care is being maintained or not, whether district TB officers are submitting their tour program to the state TB officer or not, whether they are doing the peripheral supervision or not, whether the dots is being given or not, whether their complaints are being looked adequately and timely or not. That is the issue. And the DTOs and the STS, STLSs are not visiting the patients in the periphery, or they are visiting in the state of the Orissa. That is what is my issue.
Thank you, sir. I think these are the points that we all need to think about, and I think we need to re-stress these points when we are doing trainings and retrainings. Awareness about comorbidities and management at the peripheral level and the supervision of treatment, as has been discussed in our many of our previous clinics, that all these things have to be stressed on when we are doing retraining of our staff. It's a very good point, sir, and we have noted that, sir.
Sir, I want, with permission of Dr. Behra, sir, I want to just discuss 3-4 points related to this case. One is, you see, like about the hyperproteinemia. When Delaminate was launched, as also mentioned, initially they were very strict about this, that anybody with serum albumin less than 2.8 sort of Delaminate was contraindicated. So rather, in the earlier guidelines, if you see the guideline book, if some patient when to choose Delaminate, when to choose bedaquiline, if hyperproteinemia 2.8, straight away go for bedaquiline. But gradually the evidence came that even with people who have less than 2.8, with monitoring we can consider if we do not have other options. And one study was shown by Dr. Botel of 2022 only regarding this, the metabolite of, actually the Delaminate is metabolized to a metabolite called DM6705. And two issues, the serum proteins and the CYP3A4, they are involved in this metabolism. So, and these metabolites are linked to the QTC prolongation. But now we have 2-3 studies which have shown that even in patients who have the albumin level less than 2.8, with monitoring we can give it. But in this case, the issue was patient was already having the heart which was not normal. There was dilated myopathy with digoxin. Patient also developed the ventricular bigeminy. So these are the cases where it becomes little more difficult to choose Delaminate. So the team under their care decided not to choose Delaminate, which I think was a good decision, because in these cases we can't afford to have Delaminate and expose the patient to these kind of things. So sometimes patient can die also because of the arrhythmias. And also very important point is that it is the lower level of electrolytes like potassium, calcium, magnesium, which again exacerbate the tendency for the arrhythmias. So the team, as we can see in the presentation, they kept a very good chart, maintaining the electrolytes within normal limits as far as possible. Even in routine practice also under PMDT, whenever we are treating these cases with drugs like bedaquiline, clofazimine or delamanate, we must ensure that the electrolytes are kept within normal limits, right from the day one. Although we find in the beginning of the pre-treatment evaluation, sometimes magnesium levels are not available when we are going to start. So we don't want to delay the start, but we must ensure that within 2, 3, 4 days, the magnesium levels are also available besides the calcium and potassium. So that is one thing. One point which Dr. Behra sir had raised that regarding the admission. Yes, sir, we are also noticing that we want to keep the patient sometimes such difficult cases, but after 1 month, 1.5 months, the patient as well as the family, they insist that we want to be discharged. So it becomes a challenge for the treating team whether to discharge, not to discharge, or how to convince the family for monitoring. The moment patient goes home, the monitoring becomes definitely poor. It cannot be as good as the patient is in the hospital. Then regarding the insulin, I partially agree with Dr. Potal that since the rifampicin was not being used, so the oral hypoglycemic could be, but in such situation where recently diagnosed case of drug-resistant TB with multiple comorbidities, I think insulin may be a better choice for a good glycemic control. So if we can afford that, patient can afford, then in that case, I think insulin would be, especially when a person who already went through the hypoglycemic episode, age was 50 years of age. So if we have a choice, I think we can choose insulin in such cases in the management. And once 3, 4 months pass, the patient comes out of this acute this TB episode, the comorbidities are settled down, then one can switch over to the oral. Although most of the diabetologists nowadays, they prefer insulin throughout life rather than the oral. Although there are issues with taking insulin throughout life, if I am a patient, it's easier for me to tell as a doctor that use insulin, but when once we become patient, then we prefer oral in cases. And nowadays, a lot of oral hypoglycemic drugs are available, which may be safe. But in the beginning of 3, 4 months, insulin may be better choice. Another issue was the bedaquiline interruption. So the team managed it very well that whenever they found that the QTC prolongation issue was there or patient was having arrhythmia, they stopped the bedaquiline. But this is just for revision that in the initial 14 days when we gave high dose of bedaquiline daily, then if the interruption is for less than 7 days, if interruption is for less than 7 days and we can restart, then we can continue the same regimen of bedaquiline. We don't restart the bedaquiline regimen again. But in case we find the interruption in the first 15 days is more than 7 days, we have to restart the bedaquiline first 2 weeks of high dose daily bedaquiline. So that also we have to keep in mind. In this case, I saw that the patient was stopped only for 3 days, 4 days. So I believe that they had continued with the rest of the days of these 2 weeks for the bedaquiline. And another thing is that, as they mentioned clearly, that when we are measuring the QTC levels, so what ECG machines are there in most of the states of the country, they are also giving QTC, but that QTC is desert formula, and that is very, very high compared to the what we need. What we need to take action is the QTC Fredericia, and especially when there is a tachycardia, you will find the difference between QTC by Bezet and QTC by Fredericia is significant difference. So before we take a clinical action on the QTC prolongation, please ensure that there is an app which is available. It is there in the guideline also, that do not react on the QTC given on the ECG machine unless it shows QTCF, and use that app wherein you just need to feed the heart rate and the QT interval. It gives you QTC Fredericia, and then you take a clinical action based on the QTCF. And I must say it was a very difficult case, not so easy to manage, but somehow the state team, they managed it very well, although we lost the patient and we do not truly know what could have been the reason. He had diarrhea and also developed breathlessness. So whether he died of the cardiac complication or some other complication, it is difficult to say. Amikacin, yes, amikacin already said by Dr. Portal that especially when you are giving with Lasix, the chances of water toxicity are increased. So I think in these cases, we need the audiometry monitoring much more often, so that we are able to catch it, because sometimes it is irreversible. The ototoxicity is irreversible. So in a case who is already on diuretics like Lasix, and we are forced to give injectables, we have to be very careful and do more intense monitoring. Although, you know, in most of the places we find even availability of audiometry is a challenge. It is not so easily available. Sometimes they give dates which can be in days or weeks, but we have to know that the combination of Lasix with amikacin, it can increase the chances of ototoxicity. So ultimately patient developed ototoxicity and we had to stop that drug also. But overall the ways the state team took this challenge of managing this very challenging case with multiple comorbidities, multiple ADR during treatment, and they chose the drug as per the replacement sequence of the country. I congratulate the state team, Dr. Kotal, Dr. Bindu Behra, and the entire the STO also, that they could manage this case. And through this case, I think we learned, the entire country learned a lot of points. So that is the purpose of this difficult to treat TB clinic. Thank you. Thank you for my.
Thank you. We have a hand raised from Dr. Seema Jaiswal. Dr. Seema.
Yes, ma'am. Ma'am, अरे यार मैम
हाँ बोलिए आप प्लीज।
हाँ सर, एक्चुअली एक पेशेंट हमारा ऑल ओवरऑल लॉन्गर पे है, निशांत, यंग बॉय है 25 साल का, और उसको सर इतना सीवियर बर्निंग फीट एंड पेन है कि ही इज नॉट टॉलरेटिंग। वो ऐसे मैंने अल्टी पल्टी खाते हुए कर रहा, तो उसकी हमने लिनाजोलिड बंद कर दी थी, उसको गाबा पेंटिन दिया, उसको भी दिया, और पर ही इज नॉट रिलीव्ड, और उसकी फैमिली बहुत रिलेक्टेंट हो रही है मेडिसिन के लिए, तो व्हाट शुड वी डू सर?
Okay, you see in this case, first of all, I must say that you have delayed the stopping of linezolid. That is the usual mistake which all of us are doing. Initially, when we started using linezolid about 15 years back, we were committing the same mistake. If somebody is having,
sir, actually वो he came late कि उसको ये समस्या हो रही थी, he could not understand कि ये क्यों हो रही थी, जबकि हम उसको बता चुके थे कि जो भी परेशानी हो तो तुरंत आइए। तो सर आप क्या कर सकते हैं?
I'm not blaming anyone, but what I want to convey to all the people who are attending is that
yes, sir.
What we have seen, linezolid induced peripheral neuropathy. If not managed earlier, it can become irreversible. If there is axonal degeneration, then whatever you patient may not respond. So please, we have to tell our resident doctors, our team, especially the peripheral dot provider who is in touch with the patient or the nurses, that the moment patient starts complaining of tingling, in the beginning itself, we have to take an action. That is the time that we can reverse it. Otherwise, once we can develop full axonal degeneration, then it becomes very difficult to reverse it. So you are giving gabapentin, methylcobalamin, etc. That should be given. Sometimes even tryptomer has to be given. Although tryptomer has drug interaction with bedaquiline, so that
is also given, sir.
Yeah. So he may not. Unfortunately, he may not even respond because now it has already gone to grade 3. But anyway, we have to try for that. And now linezolid is being stopped, so you have to go for the replacement sequence. So please try to go for which month it is, which month of treatment?
Sir, it's a 2.5 months, sir.
2.5 months. So this is the time we have to replace it with some drug. Delaminate will be a good choice to replace this linezolid with. So delaminate can be considered in this case. But please,
along with bedaquiline, sir.
Along with bedaquiline. Because we have seen, we have published also from NITRD that even when we use these 4 cardiotoxic drugs like bedaquiline, delaminate, clofazimine, or even high-dose moxifloxacin, under monitoring of the ECG, monitoring of ECG is very essential in these cases. These drugs are well tolerated, and it's one of the drugs, this combination, which is very effective. So especially in the intensive phase, better to give delaminate in this case and replace linezolid. But please, it's a message to all of us who are attending. We are all learning, you see, that please try to stop linezolid early rather than late, because if we are late, then this symptoms of peripheral neuropathy may become permanent. So please, we need to be careful, and we must have a period of of neurologist also. They may have something more to offer. So please take opinion of neurologist also.
Thank you, sir.
Thank you.
I think Dr. Singla, in the all oral longer regimen, probably linezolid is causing much of the havoc. And as I agree with you, if you don't stop it at the appropriate stage, it will give bad name to the program also. And people are not willing to continue. So those things has to be kept in mind very, very, I mean, honestly, when the drug has to be stopped. Because linezolid, we are also seeing, although directly I am not involved in the patient treatment, but many patients comes to us for their opinion. So this is the problem, and I agree with the appropriate time the linezolid has to be stopped and the replacement drug has to be there.
Thank you, sir. Dr. Behera, sir, any comments, last comments from you?
Yeah, I think I should say, in this particular case under discussion, he had got many poor prognostic features, prognostic factors, let me put it that way. And very rightly, you have, Nita, you had pointed out at the very beginning during your remarks that he had got many poor prognostic factors in this case. This is number one. He has got comorbidities, he had got hypoalbuminemia, he had got, he had got 3 times first he was sputum positive, then again he was sputum positive, 3rd time sputum positive. So, and then of course we do not know the grade. He had diabetes, associated diabetes. So, he has got many poor prognostic factor that we must also understand. You see, we are, and then secondly, they have got multiple side effects to various drugs, or various drugs could not be given because of associated conditions. That is number 2. And then number 3, I think I should say the team had managed the case very well. They have used the drug the way I think I would have done it in the same way. The way they have done it, I will fully agree with their approach and their line of management. But obviously, we have to understand that there are difficulties. Sometimes we face these difficulties. But only 2 things again, what we learned, then what lessons we learned from this case. The lessons we learned from this case is, number 1, this type of patients needs intense monitoring. Whatever way it is, they need a multidisciplinary approach. The endocrinologist, the cardiologist, then the chest physician, that is very, very essential. So the multidisciplinary team and more intense monitoring, let me put it that way. So this type of patient should do. And then of course, for the 4th thing, again, I would like to request the program and the state, they should see that we should not hear that, the fluoroquinolone resistance or the LPA test are not available. That should not be there. I think we at least when we are nearing 2025, these things should not happen. It is your job to find out. So that will be another thing. I do not know whether that would have made any difference in this particular case, but obviously it would have made a difference in other ways. And if it is happening for this case, it might be happening with other cases also. Because if it is not available, it is not available. That I had told during one of my earlier cases where I had also given comments. But overall, I should say all the discussions went very well. We have to handle such type of cases, hypoalbuminemia issue and delmonide, then the thyroid function test and the ethionamide, and all these linezolid, the presence of optic neuritis, the sensory, the problems were discussed very nicely and the state team. I should say I learned a lot of things. Thank you.
Thank you so much, sir. Thank you.
Dr. Singla, may I come for a minute? Dr. Singla.
Yes, sir, please.
For my ignorance, I am asking this question. Patients of tuberculosis who die during the treatment in the program, is there any provision for verbal autopsy or something to know what is the really somehow cause of the death? Is there any provision in the program?
Yes, sir. I think program is very clear that ideally any death during the treatment, the DTO and his team should do this, the verbal autopsy. And only thing is that it's a challenge. The family may not sometimes cooperate for this, but it should be done for learning. So program is
Yes,
done.
I think Professor Rajendra Prasad, may I add you to yes, there is a provision, but there are some lacunae in the presently available verbal autopsy. So I think under the global fund, the what is that? The Agra Jalma people, they have taken up a the study about the verbal autopsy, the various issues associated with that. Now they have recommended a the what way the verbal autopsy should be done. But Dr. Bansal was the PI, so that was just discussed a few days back last week. So I'm sure the program is going to take that up. They will accept that format. So it is recommended actually from the, it was a global fund project and the ICMR has recommended it. Is up to the program to accept. But yes, as Dr. Singla said, there is a provision for verbal autopsy. I do not know whether the states or the program is doing it as that aggressively. I do not know about that part.
Because you know why I said these words, Dr. Behra and Dr. Singla. You know, these are the, we are using newer drugs. They are very good drug, I know for, but verbal autopsy will able to sometimes say that whether there is some problem with drug also, because sudden deaths are known even with the drugs. So that process is to be fortified, what I believe, because death is not so common in every state. So every state can go to this and can adopt the process of verbal autopsy to know effectively. We may know something better what we know without verbal autopsy, and that may be helpful in a future patients.
Achha, Nita, can you tell us, as Dr. Rajendra Prasad is asking, do you think this patient, say for example, he died? So how it is entered in the program that the patient is died because of, as is the same question, he died because of TB, or he died of, how are you going to accept that, or he died of cardiomyopathy, or what will be the cause of death here? How it is recorded? Because you know, when you are taking the parameter of NTB strategy, the mortality has to be reduced by so and so. So how are you going to, to account for that? So what is the way? That is maybe Dr. Rajendra Prasad is trying to find out that. And I am also thinking that way, how that death is accounted for.
So to my knowledge, we are right now entering it into the NICSHE, and NICSHE is regularly monitored by the state as well as by the CTD. And the reason for death are recorded in the treatment cards. So when we are doing our quarterly review at the state level as well as at different forums, we are discussing these deaths.
Okay.
But sir, what I wanted to add was that this is the patient which reached a bigger hospital. I'm sure there are many deaths happening at the periphery where we are not doing proper pre-treatment evaluations, or we are not doing monitoring of ADRs. So for all the participants, it is like we should recognize this thing, that if we are not screening the patient at the onset at district DRTB centers, we may be missing many comorbidities and ADRs. So training and retraining of peripheral staff, of our MOPHIs, of our medical officers is definitely needed in the program. So with that, I think Dr. Gurpreet Singh, you have raised your hand. We have read your comment. So if you have to say anything other than your comment, please.
Good afternoon, ma'am.
Yeah.
my question is regarding death audits. We are doing death audit. What हम करते हैं, suppose करो पटियाला has death rate of 7%. उसमें से हमने death audit कर लिया. Delay diagnosis हो गया, accidental हो गया, जो भी हो गया. पर मैम अल्टीमेटली उसका कोई फायदा हमें टेक्निकली होता नहीं, क्योंकि हमारा जो डेथ रेट है एट द सेंट्रल टीबी डिवीजन 7% ही रहेगा. अगर हम प्रोग्राम वाइज
जहां तक फायदे का सवाल है ना, अभी क्या है, जरा सपोज you know with these cardiotoxic drugs sudden death is known to occur, although less but known to occur. In case you find no other reason but you report that out of 100 patients put on this 1 or 2% of the patient died of sudden death. So really you see this is the issue in our country, that if you see the treatment card, they are empty about the adverse drug reaction, while almost 70 to 80% of the patient on second line drugs will have some adverse drug reaction. So we do not take the adverse drug reaction seriously. I think that death audit, as sir also said, Dr. Arendra Prasad and Dr. Behra sir also, they are important to know. Sometimes we may be able to reach a conclusion that by using the newer drugs, sudden deaths, unexplained deaths have increased. So I think we should do it as you are doing. I think we should encourage you to keep on doing it and report. And what could be the outcome? Maybe the time will tell us. But I think we should do it.
Yes, Dr. Singla, I agree with you. Verbal autopsy is the rather, I can say, rather a research tool which helps in future. Something we can found that why people are, who are dying, then why they are dying, why they died. It may not be for the same patient, but it may be for next patients, for other people to learn about it. That is why verbal autopsy came way back when you know autopsy is not possible, then verbal autopsy, in place of that the verbal autopsy came. So it is going to help in the future. As Dr. Singla is saying, these are the new drugs. Sometimes sudden death do happen. Is any drug is the disease is responsible? Is there something else is responsible? So that we'll know in detail, and that will help for the future generation.
We'll take some questions there which are there on the chat now.
Dr. Sania, she has asked that if neuropathy develops after 24 weeks of treatment, then what will be for linezolid?
This is very important thing which has been asked, is that patient is almost completing 6 months of treatment on all oral longer regimen, and now develops significant neuropathy requiring the stoppage of linezolid. So what should be done? Now, patient is on 5 drugs, as you know, the all oral longer regimen, 3 group A drugs and 2 group B drugs. It's a time to stop the bedaquiline. And so when normally we continue with the rest of the. So first of all, we'll see how has been the response of the patient to the treatment. Suppose patient has clinically improved, radiologically improved, microbacteriologically he is negative for last 2-3 months. In this case, even if you stop linezolid, and you know, in case you think of the replacement sequence, from the replacement sequence in the follow-up period, usually, I'll say usually, delaminate is not to be used, although in our guideline we have mentioned delaminate is not to be used at all, but it may not be a very strict thing. If required, only then we can use delaminate, but injections definitely not to be used. So first question is, do we need to add something or not? In case we stop bedaquiline, we stop linezolid, we are left with 1 group A drug, that is the quinolone, and 2 group B drugs, that is clofazimine and cycloserine. So in case we have a patient which I described that he has improved clinically, bacteriologically, radiologically, even these 3 drugs could be enough during the continuation phase. On the other hand, we have a patient that no, even his response to bacteriological response was delayed. He converted only at 4 or 5 months of treatment. The clinical response is also not that much satisfactory. And we feel no, we should add one of the replacement drugs. In that case, we in the replacement sequence, we go for like delaminate, amikacin, we leave, and we go for pyrazinamide. If it was pre-treatment, it was sensitive. If pyrazinamide was resistant, there was INHA mutation, we can go for ethionamide. But by and large, after 6 months, even if we have 3 good drugs like 1 group A and 2 group B, even that could be enough in the continuation.
So there's another question from Dr. Ankur. He's asking that if the patient was on all oral shorter regimen and then we need to switch to the longer regimen. Does we need to restart bedaquiline in the longer regimen, or we can continue with the same?
Yes, I think again a very good question. A patient who was on a shorter regimen and either failed to that, or because of the certain ADR, we have to switch to the or longer regimen. And we decide, sometimes we may not decide to give bedaquiline. If we decide to choose to give bedaquiline in the all or longer regimen, we will count it as A1 again and full 6 months. But only thing will be that loading dose will not be given. We will bring bedaquiline again for 6 months along with the other drugs, but loading dose of bedaquiline will not be given. But here, please see, in case patient has taken shorter regimen for 6-7 months, and now you have to start the longer regimen, then the drugs which have been used in the shorter regimen, they may not be very good options, because patient might have developed resistance to these drugs, like bedaquiline, clofazimine, or the levofloxacin. That is why we say, whenever we are choosing shorter regimen for a patient, be sure that there is no contraindication to the shorter regimen before we start the shorter regimen. One of the common reasons for failing to shorter regimen is that shorter regimen was given to a group of patients where it was actually contraindicated, like severe pulmonary disease, severe EPTB disease, presence of quinolone resistance, which one came to know only after 3-4 months. So we please ensure that shorter regimen is given only when indications and contraindications have been kept in mind and they have been fulfilled. Otherwise, we will be creating more resistance in the community. Thank you.
So there's another question from Dr. Sania. She's asking, the patient was fluorescein resistant, so delegnate was given in all oral regimen, but later on patient develops and linezolid induced ADR. Then what will the treatment for linezolid?
Again, you see, in this case, if patient is still in the intensive phase and we want to give 5 drugs, in that case, what was the question? Delaminate was already added. So we go for the next replacement sequence. If we are in the intensive phase of first 6 to 8 months, injection amikacin can be chosen if it was sensitive. So that will be the first choice. Second choice will be pyrazinamide. If we have a DST suggesting pyrazinamide is sensitive. In case that is resistance, then we have to go to the third drug, that is ethionamide. The mutation was. So we follow the replacement sequence and choose accordingly, so that we have at least 5 drugs in the initial intensive phase.
Thank you. Thank you, Dr. Simla. And one question. There is a very small announcement. We are now switching over to iEcho platform. That is from the next clinic onwards. You just have to register once on the iEcho, and then you need not register every time the way we have been registering right now. So it will be much easier for you to join our clinics. We are going to make a small presentation on that. But before that, I would like to thank Dr. Ravindra from CTD, who has stayed all along with us, and his presence encourages us. Dr. R.K. Divan sir, Dr. Arvindo, Dr. Sudarshan, Padma Wardi, Dr. Digambar Behra, our director, Dr. R.K. Divan, Dr. Singla, Dr. Saroj, my team of ICO India who's here, and all the participants for being with us for so long and encouraging us and taking discussions. So now we switch over to ECHO team for their presentation. And while they prepare for your feedback, so kindly give your feedback before we close the session.
we are just giving you a brief about the IACO project. So most already are registered on the IACO and doing clinical, non-clinical and meetings in your respective states already. So just giving a brief, a short introduction of the IACO, the people who are already registered and doing their sessions on IACO, and more than 11,000 participants on IACO. It's a very user-friendly experience and it's a user-friendly interface. So you won't face any problem. It's a simple thing to use. It's very simple. You're already using a social media like Facebook, WhatsApp. So it's just like that. And you will receive an automated reminders for this session from your email, SMS, and WhatsApp. Before the session, you will receive the reminder like 30 minutes prior for your session, like the session will start with 30 minutes. So just need to click on that link and it will automatically go to the IACO platform. It's fully integrated with Zoom. And it supports multilingual. We have many languages supporting with it. Our team are also working on more to touching more lingual.